Okay, so continuing today, we will discuss some miscellaneous inflammatory conditions for the first part of the talk, and then we will discuss thoracic imaging of AIDS for the second part of the talk. So we'll start with the CT of COVID, which I'm sure most of you are familiar with. So on the chest radiograph, the findings may be fairly subtle, but if the patient has the typical symptomatology, we may see these faint ground glass opacities, especially at the periphery and at the base of the lungs. Of course, CT demonstrates them much better, and we will see these ground glass opacities, especially in a peripheral distribution. Here's another example. This was a 30-year-old man with COVID, and we can see these patchy peripheral opacities, and we can see the progressions 5 days later as they become more confluent. Then we can also see worsening on chest radiograph. Here's a 50-year-old man who has these peripheral consolidations, and you can see how this progresses a week later to the point where the patient requires intubation. So the typical findings that we might see on CT are peripheral ground glass opacities. Sometimes they may be round. There may be crazy paving. Sometimes there can be a reverse halo sign. Sometimes it may result organizing pneumonia. There are other appearances that may be indeterminate, like non-rounded or non-peripheral ground glass opacities. Atypical appearances would include consolidation without ground glass opacity or predominantly nodules, tree and bud, cavitation, smooth septal thickening. And there can be cases where there is no CT evidence of pneumonia, although in early cases of COVID can be negative. So those are the typical manifestations of COVID on imaging. Now, there are other things that can look like COVID also. Organizing pneumonia can give you peripheral consolidations, as we see here. That can resemble COVID. And then there are other viral pneumonias. This is an example of influenza A. That can also give you consolidations that may have all kinds of distribution. So there are other viral pneumonias besides COVID. One other thing to remember about COVID is that it can make patients hypercoagulable. So we may see clots. Here's a patient with pulmonary embolism from COVID, and this patient also has a clot here within the aorta. So hypercoagulability can be associated with COVID. Here we see the clot in the aorta in this particular patient who had COVID. So here's a 54-year-old man with shortness of breath and fever, has these widespread bilateral consolidations. Again, you can see it's predominantly ground glass in opacity and is diffuse. So besides bacterial pneumonias, besides COVID, well, as we've said, there are other viral pneumonias. This was influenza A, H1N1 viral infection, and here's a CT scan showing you ground glass opacities with interlobular septal thickening, and this can resemble ARDS. So there are other viral pneumonias besides COVID that might give a similar appearance. So here's a 32-year-old woman who was in the ICU for fever and respiratory symptoms. Recent travel from Saudi Arabia. We can see the consolidations have progressed over the week. And this was a Middle East respiratory syndrome coronavirus, so another coronavirus. Unfortunately, this one also has a very high mortality. So these coronaviruses can give you pneumonias in the lung, consolidations, especially ground glass opacities that may be peripheral, just like COVID can, as in this example. So let's move on to another unusual infection. If I tell you this patient has fever and respiratory symptoms, history of exposure to a white powder, and when we look on the chest radiograph, we notice there is mediastinal widening here from mediastinal lymphadenopathy and a right perihilar consolidation. Well, this is anthrax. So anthrax a number of years ago was in the news because of terrorism and this being spread through the mail. So in most cases, if it's acquired in the environment, most cases are cutaneous or gastrointestinal, so pulmonary infections are less common. But with weaponized anthrax, the type that has been associated with terrorism, the particles are smaller, and they are less clumped, which allows them to deposit in the respiratory tree. So the spores are inhaled and ingested by macrophages, and the macrophages then take them to the lymph nodes. Hence, we get these reactions of lymph nodes in the mediastinum and the hilum. When the spores germinate, the bacteria produce powerful exotoxins, and that's what results in mediastinitis and hemorrhagic lymphadenitis associated with this infection. So mediastinitis and hemorrhagic lymphadenitis. So initially patients can have fever, chills, cough, abdominal pain, and then they rapidly progresses to shock just a few days later. So early diagnosis can be important in terms of instituting proper therapy for this disease. The findings on imaging: the lymphadenopathy causes widening of the mediastinum. Consolidations tend to be perihilar in distribution with this disease. So on the x-ray, we may see this widening of the mediastinum, this perihilar distribution of consolidations on chest radiograph. And on CT, on non-contrast CT, the nodes may be hemorrhagic, hence they might be hyperattenuating, as we see in this particular example. And there can be edema within the mediastinum, and there can be this perihilar distribution of opacities like we see here as the infection spreads in the perihilar region. So we get thickening of the parabronchial tissues. You can see pleural effusions can also be commonly associated here. It can be rapidly progressive, so you see here some mediastinal widening, and then we have consolidations here that progress pretty rapidly. So pleural effusions, which may be hemorrhagic, you see the hemorrhagic fluid level here, the mediastinal lymphadenopathy producing mass effect here on the posterior wall of the left atrium and the pulmonary veins. And the nodes may also be enhancing. Here we see enhancing lymph nodes here in this particular patient. And on delayed CT, because of the hemorrhage within the nodes, you may have this peripheral enhancement within the nodes with the lower attenuation in the center, somewhat similar to tuberculosis on these delayed CT scans of anthrax. Okay, so let's move on. This patient has chest pain and fever. We see that this patient has a central line. We see a little bit of patchy consolidation here within the left lung. Well, what could be the underlying disease? If we look very carefully at the bones, we notice this funny shape to the thoracic vertebra. So this has been described as H-shaped vertebra. You can see that better on the lateral view. So, of course, this patient has sickle cell disease and is suffering from acute chest syndrome. So acute chest syndrome here associated with sickle cell is characterized by fever, new consolidations on the chest radiograph, chest pain, leukocytosis, and although some may not have consolidations on admission when they're admitted for pain crisis, they may develop the consolidation a little bit later on. So this can be caused by pulmonary infarction as a result of the vaso-occlusive disease from microvascular occlusion by sickled red blood cells, or it may be brought on by infection. So it can be infection with any of these organisms, especially more common in younger patients. So the pathophysiology here is that we can get sickling of blood cells in the pulmonary circulation that causes increased blood viscosity, decreased tissue perfusion, acidosis, which causes more sickling, so you get into this vicious cycle here with acute chest syndrome. So patients may have consolidations from hemorrhagic edema or hemorrhage with necrosis. They may have cardiomegaly as a result of the anemia, but the bony changes of sickle cell, even if you don't get the history, might help you. If you notice it on the chest radiograph, you may see infarcts within the shoulders, within the proximal humeri, H-shaped vertebra from necrosis of the end plates, so it gives you this kind of concavity here within the end plates of the thoracic spine. We may see some ground glass opacities from edema or hemorrhagic edema. Hypoperfusion, we might see that also. You can see here that there are these areas of decreased perfusion here within the lung as a result of the sickling of the red cells. And then the characteristic finding of sickle cell are these H-shaped vertebra. So you can see that very nicely on the lateral view. The end plate necrosis there causes these concavities in the end plates within the vertebra. So if we recognize that, then even if we don't get the history, we can realize that the patient has sickle cell disease. So here's a coronal and sagittal CT scan showing you nicely these H-shaped vertebra, which we can also make out on the chest radiograph. So here's a patient with sickle cell disease, and we ask the question, is there a finding? Well, if we look carefully here, the right paraspinal line here is bulging a little bit there behind the right heart border, and then we can see on CT that there is a posterior mediastinal mass in this patient with sickle cell disease. Other findings here, heart's a little bit on the big side. Also notice the small calcified spleen. This patient has had autosplenectomy as a result of the sickle cell. Again, if you don't get the history of sickle cell, seeing these findings will tell you that the patient has some sort of underlying hematologic disease like sickle cell, if you happen to notice the autosplenectomy and also these changes, the bony changes, the sclerotic bones. So what might be the diagnosis? Again, notice the avascular necrosis here within the shoulder, sclerotic bones, this posterior mediastinal mass. Well, this is extramedullary hematopoiesis, which can be associated with sickle cell and can result in this posterior mediastinal mass. Notice that it does look like there may be some fatty components here inside this posterior mediastinal mass. So again, that is very suggestive of extramedullary hematopoiesis. So let's move on. Here's a patient who has a chronic cough, and we see this consolidation here at the right lung base. We look at that with CT, and we notice that we do see this consolidation, but what is peculiar about it is that it is very low in attenuation. As a matter of fact, it is fatty in attenuation, and so that gives us the diagnosis of lipoid pneumonia. So fatty attenuation consolidation, notice the attenuation here is fat, so this is lipoid pneumonia. Sometimes we can get these spiculated masses associated with lipoid pneumonia as a result of a desmoplastic reaction that occurs around the pneumonia. Notice the fat there within the opacity telling us that this is a lipoid pneumonia. And there is a term for this kind of mass. That term is a paraphenoma. So in most cases, lipoid pneumonia results from aspiration of oily substances, most commonly mineral oil. Typical scenarios: an elderly patient with constipation or esophageal disease like reflux or achalasia who takes mineral oil and may aspirate it, and that can cause an inflammatory reaction within the lungs. You can see the fat there on the histology specimen. So initially, patients may develop a hemorrhagic bronchopneumonia. The macrophages phagocytize the oil, and that results then in these consolidations consisting of lipid-laden macrophages. And then we can have fibroblast proliferation, and that gives us some collagen around it in a desmoplastic reaction, and that's how we get the paraphenoma, which might be a stellate opacity from fibrous tissue surrounding the fatty consolidation. So with lipoid pneumonia, from aspiration of fatty substances, we can get these bibasilar consolidations as you would expect with aspiration. They may have irregular borders as you see here, but the important finding is the fatty attenuation there within the consolidation. So that is our discussion of some miscellaneous inflammatory conditions. So let us move on now to a discussion of the thoracic manifestations of AIDS. So we have a 42-year-old man who is HIV positive, and we can see that this patient has a consolidation here in the left lower lobe. So this patient has pneumonia. What is the most common cause of pneumonia in HIV positive patients? And that turns out to be just like everybody else. So community-acquired bacterial pneumonia is the most common cause of community-acquired pneumonia in patients with AIDS, just like other patients. Now, there are other infections that can also occur in AIDS patients, so we will discuss those. We will also discuss neoplasms. We'll touch on lymphoproliferative disorders and some other unusual manifestations that we might see. Now, the lung disease is related to the CD4 count in patients who are HIV positive. So when the CD4 count is greater than 200, patients may get bacterial pneumonias, or that might be the most common type of pneumonia that they get. They're also susceptible to tuberculosis, and the pattern of disease that they would get with tuberculosis is more of a fibrocavitary disease pattern, whereas when the CD4 count is less than 200, they're more likely to get lymphadenopathy or pleural effusion associated with tuberculosis. They can have atypical patterns when the CD4 count gets very low, and as the CD4 count gets lower, then they are prone to more unusual infections like pneumocystis infection, fungal infections, and then neoplasms like Kaposi's and lymphoma, especially with low CD4 counts. And then when the CD4 counts are really low, patients can get atypical mycobacterial infections within the lung and CMV viral pneumonias also. So community-acquired bacterial pneumonia, that can occur at any level of immunocompromise, but should be suspected if the CD4 count is greater than 200. So HIV positive patients are 4 times more likely to develop bacterial pneumonias than the general population. And the typical organism, strep of course is typical organism, but there are other organisms that can also affect these patients. So they may have single or multiple segmental or lobar consolidations, as in this example. Pneumonia, bacterial pneumonia in patients who are HIV positive is more likely to be multi-lobar. This is an example of a pneumococcal pneumonia in this patient. And as you can see, it's gotten much more extensive, which can occur in patients who are HIV positive. Cavitation can also occur, especially with gram-negative organisms. This is a patient with Pseudomonas pneumonia. You can see it's multifocal, and we have cavitation here in the right lung, the right upper lobe in this patient. So there's another patient who's HIV positive who has fever. The portable chest radiograph kind of looks a little bit abnormal. There are these vague areas of increased opacity. We're not quite sure what's going on, but on CT it really clears things up. We see these cavitary lesions here, especially towards the periphery. So we know then that we should be suspecting septic emboli, and the test we want to get is echocardiography, looking for evidence of endocarditis. So here's another patient who's HIV positive. Here the abnormal finding on the chest radiograph, notice the thickening in the right paratracheal region. So this patient has right paratracheal lymphadenopathy, maybe some vague nodular opacities here within the upper lobes. We look on the CT and we can see this marked lymphadenopathy here within the chest, these nodular opacities here bilaterally within the lungs. So here, a patient who's HIV with lymphadenopathy, we need to be thinking about tuberculosis. And here's another example where we have the more typical manifestations that we can see with TB, these low attenuation nodes, easier to see when you give IV contrast. You can see the peripheral enhancement here, the low attenuation nodes, and the infiltration of the perinodal fat there within the mediastinum. So tuberculosis can affect patients with AIDS, and the appearance depends on the CD4 count. So if the CD4 count is greater than 200, we can have an immunocompetent pattern with tuberculosis where we get upper lung cavitary disease and consolidations. If the CD4 count is less than 200, then we get an immunocompromised pattern, even though the disease probably represents reactivation of old disease. So these patients more likely to have lymphadenopathy, consolidations, and effusions. And on CT, we can see low attenuation within the nodes with peripheral enhancement. So upper lobe fibrocavitary disease, that's the immunocompetent pattern of disease associated with tuberculosis. Here there's right paratracheal and right hilar lymphadenopathy in this patient who's HIV positive, who also has tuberculosis. And we can see here the low attenuation here within the nodes with the peripheral enhancement, which is typical of tuberculosis. Now, atypical mycobacterial infection can also occur in these patients, and they get infection from the environment. The portal of entry is probably the GI tract. Patients may have lymphadenopathy with minimal parenchymal disease. Again, the nodes may be of low attenuation, although that's more common with tuberculosis. They can also have lymphadenopathy within the abdomen. So here's a patient who has mediastinal lymphadenopathy and some enlarged nodes here within the abdomen. So this was a patient who's HIV positive with atypical mycobacterial infection. So here's a patient who is HIV positive with atypical mycobacterial infection before antiretroviral therapy. The chest radiograph looks pretty normal. And then 1 month after institution of antiretroviral therapy, we can see here that there are these streaky opacities with some bilateral or at least left hilar lymphadenopathy here in this patient. So what is going on? 1 month after antiretroviral therapy, again, notice the flare-up of these lymph nodes, these low attenuation nodes in the subcarinal region, this left hilar lymphadenopathy in this patient. This represents immune restoration syndrome. This is clinical, this is a transient clinical worsening of chest radiographs, imaging findings, and patients who have underlying infection or inflammatory disorders who begin antiretroviral therapy. It's probably due to an improved immune function due to the antiretroviral therapy. It's also been called this heart attack. And you may also see manifestations of sarcoid associated with antiretroviral therapy when the CD4 count is greater than 200. So here's a patient with tuberculosis here. Before therapy, just some streaky opacities. After institution of antiretroviral therapy, we see consolidations and this worsening. So it's representing the immune system here that has a improved function, and that's causing the abnormalities then that we see within the chest in these patients. So immune restoration syndrome. So here's a patient who's HIV positive. The chest radiograph shows these interstitial and ground glass opacities. The patient is short of breath, and on CT we can see predominantly ground glass opacities. Well, that is a hallmark of pneumocystis pneumonia, mostly ground glass opacities in these patients. Of course, nowadays it could also be COVID, but this was pneumocystis. Characteristic feature of pneumocystis, in addition to the ground glass opacities, is formation of pneumatoceles. So if we see pneumatoceles in patients who are HIV positive, combined with ground glass opacity, that's a pretty good appearance for pneumocystis pneumonia. So this is a unicellular organism, behaves like a protozoan, although it is classified as a fungus. So this is very common when the CD4 count is less than 200. The patients will have fever, cough, shortness of breath, hypoxia, chest x-ray, usually normal, although it begins as this fine granular or reticular opacities, usually bilateral disease, and patients can go on to develop pneumatoceles, especially within the upper lungs. Even when the chest x-ray is relatively normal, if this is suspected, it is an indication for CT. The CT can show ground glass opacities here within the lungs from active pneumocystis infection. And then when these patients develop pneumatoceles, they can develop pneumothorax as a complication, which can be very hard to treat. You can see pneumatoceles and a large pneumothorax on the right here in this patient as a result of the pneumocystis pneumonia. These patients don't heal well, so often the pneumothoraces and the leakage of air may be refractory to chest tube treatment. So you can see that large pneumothorax and extensive subcutaneous air accumulation in this patient as a result of the pneumatoceles and the pneumocystis infection. So this patient is also HIV positive. We look on the chest radiograph, we see these fine nodular opacities that are scattered bilaterally. The patient also has a left pleural effusion. So what might this represent? Well, the first thing, of course, you might be thinking about is miliary tuberculosis, but there are other infections that can also give a miliary appearance in patients who are HIV positive. This happened to be cryptococcosis. So cryptococcal infection is the most common fungal infection associated with AIDS if we exclude pneumocystis. Usually the CD4 count is less than 100. This is associated with cryptococcal meningitis, which can appear along with the pulmonary infection. Patients can develop consolidations, cavities, nodules, or adenopathy, and a miliary pattern might also occur, as in this particular patient. So here's a patient who developed a cryptococcal abscess here within the lung. Other infections that can occur is aspergillosis. This can occur if the CD4 count is less than 50. The patients can get tissue invasive or angioinvasive aspergillosis, and we've discussed in an earlier lecture what that would look like. Cavitary lesions as a result of pulmonary infarction from angioinvasion. So we might see that with invasive aspergillosis, but another form of invasive aspergillosis that these patients can also get is airway invasive aspergillosis. This can affect the trachea and might affect the small airways. So these patients might have nodular opacities along the tracheobronchial walls, tree and bud opacities here within the small airways from airway invasive aspergillosis. Now, viral infections like CMV also can occur if the CD4 count is very low, and these patients can develop diffuse opacities within the lungs. Difficult to diagnose the CMV viral pneumonia because it requires cytomegalovirus recovered by culture, inclusion bodies, or progressive pneumonia that responds to the antiviral treatment for CMV. So often these patients have infection with more than one pathogen if they have CMV pneumonia. But it can manifest as diffuse ground glass opacity, as we see in this particular example. Again, nowadays, of course, COVID could also appear like this in patients with AIDS. Another unusual infection, bacillary angiomatosis. So this can mimic Kaposi sarcoma because the patients might have lesions on the skin. The patients might also develop lymphadenopathy, and it's caused by exposure to cats and cat fleas. So the patients can have these skin lesions that mimic Kaposi sarcoma, and they can have pulmonary symptoms as a result of the infection. They can have endobronchial lesions, they can have pleural effusions, they can have mediastinal lymphadenopathy, especially enhancing lymph nodes. So consider this infection in patients with lesions resembling Kaposi's. So they can have nodules like this that we might see within the chest, and they might have sometimes lesions that also resemble Kaposi's. So here's another case, and this patient has this interlobular septal thickening, but in addition to that has these kind of irregular nodules, especially nodules that seem to be this forming around the perihilar vessels and airways. So this peribronchial vascular distribution of abnormalities, well, this is Kaposi's sarcoma. So this is the most common malignancy associated with AIDS. Usually the CD4 count is very low. The causative agent is probably herpes virus 8, or it's Kaposi's sarcoma-associated herpes virus. 90% of those with pulmonary involvement have skin lesions. So if you're considering this, ask about skin lesions. They can have airway involvement along with parenchymal disease. And what can be typical is this bronchocentric or perihilar distribution of abnormalities, this peribronchial vascular distribution of abnormalities that we can see on the chest radiograph and also on the CT. So you see this perihilar distribution of these irregular opacities. So these have been called sometimes these flame-shaped opacities because of the irregular shapes. And these can enhance when we give contrast, so the lesions are hypervascular. So flame-shaped parenchymal opacities, peribronchial vascular distribution of abnormalities, that's what we can see associated with Kaposi's sarcoma. Here's another patient who is HIV positive. This patient has multiple nodules here. Of course, we might think of infections, unusual infections like fungal infections. We might think of Kaposi sarcoma, but another neoplasm that can also occur in patients who are HIV positive, the other neoplasm to consider is non-Hodgkin's lymphoma. So lymphoma is the second most common intrathoracic malignancy associated with AIDS. Usually CD4 count is less than 100. Usually it's aggressive B-cell non-Hodgkin's lymphoma. The intrathoracic disease may be extranodal. They don't have to have lymphadenopathy. They may have multiple nodules. And sometimes it can be associated with cavitation, and of course they might have lymphadenopathy. Lung cancer, there's a small increased risk of lung cancer also associated with AIDS. When it does occur, though, it tends to be much more aggressive, so more poorly differentiated and rapidly growing. This one you can see is invading the chest wall in this particular patient who's HIV positive. So here's a young patient who's HIV positive, has these small nodular opacities we can see at the lung bases. Of course, you might be thinking biliary tuberculosis. So we have these small nodular opacities here at the lung bases. When we look on CT, we notice also that in addition to the nodules, the patient also has these small cysts. And then when we look at the nodules seem to be outlining interlobular septae. So these nodules kind of suggesting a perilymphatic distribution here. So what could this be with a perilymphatic distribution of nodules and cysts? Well, this is one of the lymphoproliferative disorders associated with HIV. This happens to be lymphocytic interstitial pneumonitis. There are other lymphoproliferative disorders that are also associated with HIV. But for LIP, lymphocytic interstitial pneumonitis, so here there's infiltration of the lung interstitium by mature polyclonal lymphocytes. So that differentiates this from lymphoma. These are polyclonal lymphocytes as opposed to lymphoma, which is not polyclonal. So this usually does not progress to lymphoma in patients with AIDS. So these patients may have reticular, nodular, alveolar, or mixed opacities, so lots of varied appearances that can be associated with LIP. Patients might have nodules, as you see in this example. They can have ground glass opacities. The cystic lesions tends to be the most specific finding associated with LIP. These patients might also have lymphadenopathy. So these cystic lesions, which are thought to occur from air trapping as a result of the proliferation of the lymphatic tissue around small airways, this tends to be the most specific feature of LIP. So if we see some nodules with cystic lesions like this in a patient who's HIV positive, we should consider then LIP. So the nodules can be peribronchovascular, can have a perilymphatic distribution, and as we've said, the cystic lesions can also occur. So this combination of cystic lesions and nodules, especially with a perilymphatic distribution of nodules, should bring to mind LIP in patients who are HIV positive. Now there are other lymphoproliferative disorders, so I've listed some of them here that might also occur in patients who have AIDS. So here's an example of a nonspecific interstitial pneumonitis. So this patient has these kind of nodular opacities, as we see here, scattered throughout. You can see a reticular nodular pattern here on the chest radiograph, so no way really to make this diagnosis prospectively, although it is something to consider in the differential diagnosis. Now, if I tell you that this patient is HIV positive and we look on the imaging, we notice that there are these enhancing lymph nodes in the axilla, also some enhancing nodes in the mediastinum, enhancing nodes in the axilla, some perihilar lymph nodes. Well, what could this be? What might give you enhancing lymphadenopathy in patients with AIDS? Well, some of these things we've covered already. So, of course, Kaposi's sarcoma is a vascular disease that can give you enhancing lymph nodes in patients with AIDS. We've discussed bacillary angiomatosis that can also give you enhancing lymph nodes in patients with AIDS. But the other thing to consider, one of the lymphoproliferative disorders here associated with AIDS is multicentric Castleman's disease. So that happened to be the diagnosis in this patient. So multicentric Castleman's disease can be associated with AIDS. This is a B-cell lymphoproliferative disorder. So patients can have fever, weight loss, anorexia, lymphadenopathy, splenomegaly, and CD4 count tends to be less than 350. And patients will have enhancing lymph nodes in the axilla, mediastinum, and hilar. They may also have parabronchovascular nodules associated with this. So moving on, our next patient who's HIV positive, we notice this marked enlargement here in the main pulmonary artery. There's also enlargement here of the right pulmonary artery. You can see on the lateral view this enlargement of the main and the right pulmonary artery here, enlargement of the left pulmonary artery there. Notice the right ventricle here also appears enlarged. Well, this patient has pulmonary hypertension associated with HIV, and we can see that nicely on the CT, showing the marked dilatation of the main pulmonary artery and the right and left pulmonary arteries also on the CT. So pulmonary artery hypertension, this can affect a very small percentage of patients with AIDS. It doesn't seem to be related to the length of the disease or the CD4 count or complications. So these patients can develop a plexogenic pulmonary arteriopathy secondary to HIV, similar to idiopathic pulmonary hypertension or primary pulmonary hypertension that tends to affect young females. So pulmonary artery hypertension, a very small percentage of patients with AIDS can also, or patients with HIV, can also develop pulmonary artery hypertension. Manifestations are just what you would expect. So dilated right-sided chambers, right atrium, right ventricular hypertrophy, and this finding here of the dilated main and central pulmonary arteries, the usual findings in patients with pulmonary hypertension. Now, if I tell you this is a 22-year-old man who is HIV positive, we're looking at some MR images, and we notice these large cystic lesions here throughout the anterior mediastinum. So what might this represent? Well, these are occurring here within the thymic gland. This is multilocular. This is a multilocular thymic cyst. So this is something else that might occur in patients who are HIV positive. So this resembles the lymphoepithelial cysts that might be seen in the parotid glands in these patients, and a manifestation is as the septated multilocular cystic masses within the anterior mediastinum. So multilocular thymic cyst, cystic lesions here in the anterior mediastinum that we might also see in patients who are HIV positive. Okay, so that concludes our discussion of pulmonary diseases here in patients with AIDS. We've covered infections, neoplasms, and lymphoproliferative disorders, multilocular thymic cysts, and pulmonary arterial hypertension. Thank you for your attention, and we'll see you next time.